hear it firsthand. And our recording has begun, so once again, I thank all of you for joining us, and I thank the Virginia Rural Health Association and the Kentucky Rural Health Association for sponsoring this webinar. Let me start out today by giving you an overview of our agenda. We'll start out with some brief introductions. Then we're going to give you an overview of the impact of the Affordable Care Act reforms on rural America. We're going to take a look at the question, are you ready to pursue funding opportunities to let you take advantage of some of these reforms? And then we're going to talk about finding funding opportunities for rural communities and trends that we're seeing happening right now. If any of you at any time are having difficulty either hearing the speaker or seeing the presentation, please feel free to type into the message box at the side and let us know, and we can try to help you address that. Also, if you all have any questions as we go along, please type them into the message or the chat box, and we will try to answer them either as we go or at the end. So let me start off with, again, some brief introductions. We are Healthcare Solutions Connection. Today you're going to hear from four experts from the Healthcare Solutions. Are you all getting an echo?
Yes.
If you are, I apologize. We'll try to remedy that. You are hearing from four experts from the Healthcare Solutions Connection Network. My name is Carrie Nixon. You'll also hear from Gwen Matthews, Louise Mathias, and Carson Porter. So I am Carrie Nixon, and I started out as a healthcare attorney focusing on the Affordable Care Act reforms. I am also managing principal of Nixon Law Group and a founding member of Healthcare Solutions Connection. Gwen Matthews is a senior partner and a founding member of Innovative Funding Partners. Prior to founding IFP, Gwen was a partner at Strategic Healthcare, a DC consulting firm, and she served as administrator of the Federal Grant and Fundraising Services Division. Louise Mathias, who we hope will be joining us, is also a senior partner at Innovative Funding Partners, and she has over 12 years of federal grant development and grant management experience, most recently as Vice President of Federal Grant Development and Training at Strategic Healthcare. She also oversees the federal grant development process, writing complex federal grant and cooperative agreement applications to fund various agencies, to funding agencies such as CMS and the CMMI, HRSA, USDA, the Department of Education, SAMHSA, and others. Finally, we have Carson Porter, who is also a healthcare attorney with many years' experience in the healthcare field, including as CEO of 3 various healthcare companies during the course of his career. I'm going to now turn it over to Carson Porter to give us a dose of healthcare reality.
Well, there's a famous old saying, out of chaos comes opportunity. And healthcare reality is embedded in chaos today. And it all began with the implementation passage of the Affordable Care Act, which was clearly designed to revolutionize the way we deliver healthcare in the United States, with its new triple aim of improving the population health, improving the health of individual patients, and at the same time reducing cost. And anybody affiliated with healthcare for very long would probably say that's a big order. But it's a big challenge, and challenges create a lot of opportunities as well. So change has arrived. When you look at the data about our healthcare delivery system as compared to others in the World Health Organization every year or two publishes a listing looking at 191 different countries. And on everything except cost, the United States is buried around 30th to 35th in terms of outcomes, quality, etc. However, in terms of cost, we are number 1 with a bullet and going up faster than anybody else in the world. That's unsustainable. I think everybody agrees with that. So the movement that's now on the table is to go from interactions with patients to patient-centered care based upon evidence-based medicine. Lots of new tools coming on the marketplace, creating a lot of confusion as to whether any of these tools will really be effective. Also, at the same time, people are looking at new ways of paying for our healthcare delivery system. Cost has spiraled out of control. So how do we get it under control? And one of the approaches, of course, is to reward people for saving dollars within the system, paying for value, paying for outcomes, not just effort. Instead of every time you touch Granny getting paid for it, what are we really doing for Granny, and what is the quality of that outcome, and that will determine how much we're going to be paid. The next slide, which I unfortunately did not come up on my computer, but I will look over here just a moment. Can you tell me what the next slide is, Carrie? It's not on my computer.
Sure. It's a look at the current reform landscape.
Carrie, I'm sorry. I'm going to have to pass it back to you. I can't see any of the slides.
Okay. Sure. So let's take a look at the current reform landscape. And, you know, many of these are not going to come as a surprise to any of you. They've been in the news. They've been talked about extensively. The first thing that is probably on many of the minds of the folks of this call is Medicaid expansion.
Carrie, I
this
was
has
able
been
to
an
fix my problem.
Okay.
You're going to be surprised that I was able to fix my problem.
We're glad you were able to, Carson. I'll turn it back over to you.
Well, what Carrie was just getting ready to say, and which a lot of people on this call are very much aware of, Medicaid expansion has provided tens of millions of dollars of new federal funding for states which agreed to accept the expansion monies. I'm originally from Kentucky, grew up and practiced law in Kentucky for many, many years, but now live in the Northern Virginia, Washington, D.C. area. And when you compare the approach in Virginia to the approach in Kentucky, they're diametrically opposed. The government of Virginia has steadfastly refused to receive any of the federal funds and also refused to create its own state-based exchange. However, across the state line in Kentucky, they did embrace the Medicaid expansion program, and they created their own exchange called Kentucky Connect. The difference is there's hundreds of thousands, the number in my mind is 400,000, Kentuckians who now have access to health care delivery who never had it before. On the other hand, there's hundreds of thousands of people in rural Virginia who have been denied access to the same sort of health care coverage because of the position of their state government. Now, these are not isolated examples, as we all know. Only 26 states across the country, about half agreed to develop their own programs, and about half decided they weren't going to do that. So the health insurance exchanges, as they were originally called, now called health insurance marketplaces, cropped up, and Kentucky Connect being a classic example of one run by a state. You also had the federal government exchange, which we all read about so much in the paper, about the difficulty in getting it launched. I'm proud of my old friends in Kentucky because they've probably created one of the most efficient and useful exchanges in the country. And I would love to see Virginia, and I'm sure the people on this call from Virginia would agree, to see Virginia embrace the same sort of activity and bring that kind of care to rural Virginia. CMS Innovation Center was established in order to identify innovative ways of delivering care, enhancing patient-centered care, and paying for that care. And out of all of that came something new called accountable care organizations. I'd like to hand it back to Carrie now to talk to us about ACOs, accountable care organizations.
Sure. Thank you, Carson. ACOs really are, only one part of the Affordable Care Act reforms, but they certainly are a visible part. And they have been in the news lately, particularly in the healthcare trade press. The question is whether they're working, whether they're not working, whether they're helping to save money, whether they're not helping to save money. So they're only one part of the reforms and one part of what we'll talk about, but I thought it was a useful example to highlight today. So what exactly is an ACO? Well, the formal definition is an alliance of physicians, hospitals, and other providers that coordinates care for a particular group of patients to improve quality and reduce costs. And the key phrases are underlined there. Coordinated care, improving quality, groups of patients, reducing costs, and alliance, frankly, is a really big part of it as well. So let's take a look at how all of that is playing out thus far across the United States. You should see in front of you a geographic distribution of the MSSP, the Medicare Shared Savings Program, ACOs, as they are assigned by patient population. Now, there are private ACOs that are popping up here and there through various health plans as well. And this map really just shows the Medicare Shared Savings Program ACOs, of which I believe there are 259 to date, with more coming online, certainly by the beginning of next year. You'll notice in looking at this map that the highest density of ACOs are located in, for example, Southern California, Florida, Maryland, and New Jersey. The lowest density of Medicare-assigned ACOs are, by and large, in more rural areas. Now, if you look at Arizona there, that's actually an exception. They've been doing some really good work sort of across the board. But, if you look at South Dakota, for example, you see absolutely no touch from ACOs. So, why is it that this is the case? Some of the barriers, frankly, are imposed by the ACO rule itself. There's a requisite number of Medicare beneficiaries that must be assigned in order for an ACO to be certified as an MSSP ACO. And sometimes it's difficult for rural providers to achieve actually 5,000 Medicare beneficiaries in there because, by definition, rural areas tend to be low population areas. And so finding 5,000 Medicare beneficiaries, cobbling them together, can be viewed as a barrier. But the good news is that there are some innovators in rural health who are finding ways to work with this. So one thing that's not always obvious is that actually the ACO rule does not impose any geographic constraints or barriers to where an ACO is formed. So, for example, one rural ACO that's currently in existence is actually a network of clinics in Michigan, California, Oklahoma, and Indiana. That's that is one ACO, and that's a really interesting example of how the populations of rural clinics that are certainly far away geographically dispersed have come together to actually form an accountable care organization. So it's an example of what at first might have seemed a challenge may actually be viewed as an opportunity. And so with that, I want to turn it back over to Carson to talk a little bit more about various challenges and opportunities.
In the Chinese language, they have many, many, many characters. One character has two separate and on the surface conflicting meanings. It's the only one in their whole language. That particular character stands for both challenge and opportunity. It's because in China, people view a challenge as a new opportunity. And you have to look at the context of the phrase in order to determine whether the person who wrote that sign was talking about challenges or opportunities. Well, certainly here in the United States with the healthcare reform, we have a lot of challenges, but it's also leading to a lot of new opportunities. CMS has been dedicated to support innovation with new grants and new funding opportunities. We're increasing the number of insured or people who have access to care, and there's so many wonderful stories about how that's impacting the lives, particularly in rural America. The friends from Kentucky who happen to be on this call, I read an article from one of the national trade press within the last 2 or 3 months about some classic examples of people in rural Kentucky who had never had access to care whatsoever and how they were now improving their lives, dealing with their diabetes, dealing with their obesity, dealing with their smoking habits, getting access to care and drugs they never had before because of the implementation of the Affordable Care Act. So more and more people are becoming insured one way or another and gaining access to care. It's also breaking down geographic boundaries because we see, as Carrie just pointed out, organizations over multiple states being formed in order to bring care to targeted populations. Technology is, as we all know, every day in our normal lives as well as in healthcare, is booming, and the technology infrastructure is changing rapidly. There's new technical support, but also underpinning all of this is new and innovative funding opportunities, and that's where innovative funding partners comes in. Gwen Matthews and Louise Mathias and their team of experts are some of the leaders in the country in assisting their clients to achieve Medicare Shared Savings Program benefits and certification, and access to some of the other programs on the federal and state level that will provide funding to people who are interested in pursuing these new opportunities. So without further ado, I'd like to turn it over to our friends at Innovative Funding Partners to really drill down into the granular level and share with our audience some of the programs and suggestions they may have to be followed up on by people on this call. Gwen, Louise, which one wants to go first?
Carson, this is Gwen. I don't think that Louise was able to get in, so
that's too bad. Well,
did not work. Yeah.
Then we'll rely on you, Gwen.
Okay. Well, when we talk to our clients who are interested in grants and the various funding opportunities that come out through the federal government, we always start with helping them to look at are they ready, and it's really important to ask yourself this question because doing federal applications, whether it's the normal grants that you see from HRSA or USDA or the CDC or any of SAMHSA or any of those, really are not for the faint of heart. They take a lot of time and commitment, staff time, working with community partners, all of that. So it's important to really know if you're ready. And the number one item on this is to really make sure that you have buy-in from the C-suite. It's sort of a trickle-down effect, so to speak, in terms of if the C-suite sees that they do have priorities that can be funded through federal grants, then typically we see a much better experience on everyone's part, not only in terms of bringing community partners together, but also in terms of successful applications. So I would always recommend to people to make sure that you have a conversation with, the folks in the C-suite, what are the organizational priorities, and then begin to be very proactive. If you know that HRSA grant that is a good fit for your project, it's not going to come out for another year, don't wait till, 11 months from now, but go ahead and pull your community partners together, hammer out what you want that project to look like, what your goals and objectives and outcomes are going to be, and begin to share that vision with other members of the team, other members of the community, et cetera. And the next part is managing all those partners, the C-suite, et cetera, their time and expectations. The federal grants world is very, very competitive. The typical federal agency only funds around 10 to 15% of the applications that they receive. So it's a lot of work, and the likelihood of success is not high, but you do your homework right, you can be successful, and it is a very profitable, and we know lots of folks who raise millions of dollars every year towards their priorities because they've learned to really be very effective in recognizing which priorities are fundable, putting together community partnerships, making sure that they're managing their time between putting that project together and when the funding opportunity comes out. And so it's just very important. I won't read you everything on this checklist because we want to be mindful of time here, but these are items that we've found along the way really are important things to think about, from is it a priority all the way down to, what in the world do we do after we get an award? So, hopefully you'll go back and take a look at this. If you've not stuck your toe in the federal grant pond, these are some of the things to consider if you do decide you want to jump in. Next,
Gwen, let me interrupt you for a second. Gwen?
Yes.
I'd like to underscore one of your points. Carrie and I were asked to work on a project last year of an organization that wanted to pursue some federal grants and also Medicare Shared Savings certification. And your point about the C-suite support was very important. The CEO appointed one of his vice presidents to go get this done. However, he didn't take anything off the plate of the vice president and didn't provide him with any resources other than this one individual. So as you can imagine, finally, with about a week to go, they just threw in the towel and said, this isn't going to work, which, of course, we've been telling us for a long time. And I think it's a dramatic example of it's not just does the CEO say, boy, I really want to do this. It's does the CEO say that, plus here are the real resources to get it done.
Well, and I think, to emphasize that point, when we do what we call a readiness assessment to help an organization decide what are their strengths and weaknesses and what do they have to do to sort of get ready, we insist on talking with the C-suite group, and it's for this very reason, is so that they really understand, what they're getting involved in and what the time and expectations are of their team, in terms of everything else that they have on their plate. So, the healthcare world continues on. There's still patients to see, an organization to run, all of those things, but sometimes people, if it's really important, you have to figure out how to move something off of somebody's plate in order to get it done. So, and get it done correct. It's not just getting it done; it's getting it done correctly so that you're successful. So, no one wants to spend all that time and then not be successful. So, all right. So let's move on and talk about funding opportunities. Certainly, there are many, many more opportunities than what we have listed here, but we thought we would focus on those that really had a rural focus. All of the funding opportunities that you see, unless it specifies that they do not want a rural applicant, which I've not seen in all the years that I've been doing grants, they're all open to rural areas. But there are some that are very targeted to rural areas, and those are the ones that we're going to talk about today. Currently, the FCC has what is called the Healthcare Connect Fund, and each year for, I think there's 2 more years left in their cycle, there will be $400 million available annually for rural communities. Now, they really want collaborations between nonprofit hospitals, clinics, community centers. It can be post-secondary education groups. It can be all kinds of schools, libraries, whatever you can put together in terms of the consortia. The golden rule is that 51% of the consortia have to be in a rural area. So, if you wanted to team up with hospitals that were considered urban, as long as your consortia had 51% membership that was rural, you can apply to the Healthcare Connect Fund. And obviously, if you have 100%, you're in even better shape. The current cycle is winding down. They will be finalizing those project applications over the next month. But when I went in and checked recently, I was very shocked to see that only a very small amount of that $400 million has actually been committed. Now, perhaps in the next month as they wind down, they'll commit a lot more of it. But at least as of last week, there were, out of that $400 million, only $4 million, which is about 10%, have been committed. So it's too late to apply for this year's group, but I think it speaks well that if you're interested in, broadband connectivity for your communities and broadband networks and all of that, then you really want to look into the Healthcare Connect Fund. And we have provided a link there that you will see. If you go in and click on that link, it will take you to all the information you need on and how to go about beginning to pull your application together for next year. So again, emphasizing that point that you don't want to wait to the last minute. You want to get started now for next year. And it could very well mean some significant dollars for your community in terms of bringing broadband connectivity to your communities. Another opportunity, this one we've worked with a lot of rural hospitals. It comes out of HRSA's Office for the Advancement of Telehealth. And again, the applicant can be urban, but it has to focus on providing services in rural areas. And typically HRSA grants, 40% of the grant can go towards equipment, any technology that you have in terms of establishing a telehealth program. 40% of that can go towards your budget. The rest can be staff, space, consulting fees, that training, all of those kinds of things. But the focus is really, again, on serving rural communities and underserved communities. One of the, I think, most rewarding projects we did was through this opportunity, and we had an urban client in Arkansas that partnered with about a half a dozen small rural hospitals in other states, and this goes back to Carson's discussion about sort of the dissolving of geographic boundaries. And their hospital worked with hospitals in bordering states that were in rural areas, and one was on an Indian reservation to develop a telestroke project. And it was really gratifying because one of the hospital CEOs picked up the phone. Gosh, it was probably 2 years after we submitted, and they got this grant, and called me and just said that he wanted me to know that the very first week that this telehealth stroke project was in effect, it in fact saved 2 lives because they were able to, while a patient was in transit, talk with a neurologist and take action that ended up saving those patient lives. So, these are initiatives that aren't just on paper and that someone somewhere else receives and gets. These are actual opportunities that you, through the rural hospital associations, through your various partners, could actually pursue and help make a huge difference in your communities. The other grant that we have here also is through HRSA's Office of Rural Health, and it's a planning grant. This goes back to, having a game plan. We want to go after that Office of Telehealth grant, but, we're not quite sure what project we want to do. This planning grant comes out every year, and you can receive up to $85,000 and use it as a building block for what is their a 3-year award that they have, which is the Network Development Implementation Grant. So if you do this correctly, you have a year of planning paid for and then 3 years of a Network Development Implementation Grant. And the Network Development Implementation Grants in the past have been up to I think it's $220,000 or $240,000 a year for up to 3 years. So it really can be a significant amount of money in terms of building your rural telehealth network throughout your communities or across the state. Again, there's a hyperlink in here under eligibility, and it takes you to HRSA's website where you can determine, and many of you are probably familiar with this already, but in case you're not, it helps you really decide by county and or census tract what is urban and what is rural. And we found it to be very helpful because we found folks who thought they were rural and actually ended up being urban, so according to HRSA.
Gwen, I wanted to bring to your attention that one of our attendees has asked a specific question as a quote about senior centers and what might be available for senior center operators. I don't know whether you're going to plan to cover that or not, but if you have an answer or point out in the right right direction that would be helpful to that individual.
Oh, okay. Thanks for the question. It didn't show up on my end. But certainly senior centers, you do not have to be a hospital to apply for any of these grants that I've talked about. So, if the hospital or FQHC or rural health center or whatever it might be is you're going to partner with them, or if you have other faith-based and community-based organizations that you want to team up with, then certainly there is nothing that would prevent you from applying for any of these grants that we've just talked about.
Thank you, Gwen.
You're welcome. And this next slide is the Rural Health Network Development Program grant that we just talked about, that where you would then begin to implement and I apologize, it's $180,000 a year, not $240,000 for 3 years, but still a significant amount of money. It's close to $500,000 that you would receive over the course of 3 years to implement your telehealth network or to develop your rural health network. And then finally, the other opportunity that we've outlined here is the USDA Distance Learning and Telemedicine Grants. And excuse me, USDA has been doing this grant for a number of years. It strictly pays for technology, equipment, and any associated costs. Now, it can be distance learning if you want to develop a learning network, whether it's to help providers keep up with their continuing education, or if you want to educate providers on changes in Medicare, Medicaid, how to develop a medical home. It could be a number of things. Certainly distance learning is one way that you can use this. The way that we have seen it most used is through, again, telemedicine. About 2 years ago, we helped a group in North Carolina to install robotics in their rural hospital emergency rooms to assist with stroke patients. And we also helped about 2 years ago Norton Health System in Louisville to set up a telehealth network with a number of rural communities for specialty care. So again, there can be a wide variety of uses of this. It's the limit being, I guess, your ability to be creative on how you might use it. The eligibility requirements in terms of USDA is sort of unique. They have a very complex scoring mechanism for rurality. They also look at economic need through the National School Lunch Program. There's a requirement that you have at least a 15% match, but they are one-time only, one-year grant. It's not 3 years like HRSA, but we found that the folks who receive these really end up doing a lot of good work with these dollars, and would encourage you to certainly think about applying for this. It's a very, because it's usually technology, the equipment, and vendor costs in terms of training and so forth that are the parts that clients are least likely able to pay for. And so this is the kind of thing that the distance learning and telemedicine grant supports. Right.
Gwen,
now,
your colleague Louise has joined our program. I wonder if she has anything she'd like to add. Although in a note, she told me you're doing great, so maybe she wants to add anything.
You better tell me that.
Thank you for covering for me, Gwen, while I had technical difficulties. I really don't have anything to add at this point, but if questions come up at the end, I'm happy to jump in and help answer them.
Right. Okay. The next slide really are some links to funding resources that we thought you might find helpful. And looking at the first two, grants.gov is the federal portal where the majority of federal agencies post their grant announcements, and where the majority of federal agency funding opportunities are submitted. The reason that I put HRSA here is that while many of the federal agencies no longer post their funding opportunities on their website, there are some like HRSA that do. They post their current opportunities. They have a database that you can use to go in and look at previous opportunities. They're very good at providing you overviews of projects they funded. Their staff is very user-friendly in terms of responding to questions. So it's one of the reasons, and they have an Office of Rural Health. So it's one of the reasons that I listed them here, because I thought it would be a good resource. In terms of the foundation side of the funding opportunities, there are a wealth of online databases, and I've only listed a few of them here. And these are ones that we're familiar with, that we've used in the past, and are relatively user-friendly. Some of these have a free version that's very limited, while others have fees attached to them. But again, they're very good resources to use in terms of looking for funding for your project. And then finally, we wanted to talk about trends, and hopefully Louise can sort of jump in here and help me with this. I would really like to sort of link this back to Carson and Carrie's initial conversation about the Affordable Care Act and some of the changes it brought. And probably the biggest change that many of you all are aware of, I think, is from CMS, and that was the triple aim of better models of care, better patient outcomes, and lower cost of care. And as a result of those three initiatives came the fourth item on here, which is new payment models. And I've listed just in sort of bullet points here after each of these bolder bullet points, some thoughts related to that. But what I'd really like to talk about is the fact that the Affordable Care Act and the changes that I think many of us saw coming over the course of a decade were really to bring a lot of folks up to where some of the trendsetters, such as Geisinger and Kaiser Permanente and Cleveland Clinic and Intermountain and some of the other health centers that participated in some early CMS pilots and demos were out ahead of the curve. And so the Affordable Care Act, and I think some of a lot of the grant funding that we see are all intended to nudge folks in this direction of meeting the triple aims, and to help CMS and the federal system as a whole to evaluate new payment models, as well as new patient models of care, and to improve outcomes. So the challenge, I think, in the future is going to be that this is not an end point. It's only a beginning point. And so I think, while rural America probably is struggling to figure out how to even get to this level, I think it would serve you well to think about not only how do we get to this level, but, do we have the innovation, the experience, the knowledge of our patients, et cetera, to either take these models that the Kaisers or the Cleveland Clinics or the Geisingers have developed and apply them to a different patient population? Do we have ways to tweak those models to improve patient outcomes? And so the challenge is, as I said, is to be innovative and creative. and also to think about what does Innovation 2.0 look like. What are there models, payment models that maybe CMS has not considered? You know, we all hear about ACO MSSP and bundle payments and some of the other opportunities that have come out, but I think CMS and the other agencies are really looking for someone to take this to the next level, and maybe the challenge is to, you know, for rural America to really think about, you know, their patient populations and how they provide care, and is there a way to, as I said, escalate this to Innovation 2.0. And Louise, I don't know if you want to add to that or not.
Sure. So I think, yeah, what we've really seen is that in a lot of ways, the pilots and demos that CMS are putting out are really affecting what the other federal agencies like HRSA are doing. And so, you know, whereas it used to be a few years ago, you know, you wouldn't really have to talk much about cost savings. Now they expect you to do that. It's become much more focused on evidence-based medicine and being able to cite what models you're using, although you may very well be, of course, adapting them for your specific population, which is totally fine, but they want a kind of awareness of best practices and so forth. And so that is making it more challenging, but if you're able to incorporate those kinds of things into your proposal, you're definitely going to be an advantage to, you know, as opposed to some groups that are not able to do that. So I think it's really demonstrating an awareness of what's going on in healthcare in the big picture kind of way, tying everything back to the AAA wherever you can, and, you know, just really understanding that the whole landscape has been affected by these changes, and the requirements are getting more stringent, I think, particularly around evaluation, you know, demonstrating specific outcomes as they relate to patient care and then lower cost of care. So.
Louise and Gwen, that's fabulous. We have another specific question. I'm not sure whether you're prepared to answer it, but you might address it. The question is, are projects that focus on preventative care, such as trying to address childhood obesity, eligible for funding under the ACA or other entities?
Right. Well, I think that the rural health development grants that Gwen talked about, you know, there's that series of two. There's the planning one and then the implementation one. Both of those have sort of changed their focus in the last couple of grant cycles to really focus on preventative care. And so, you know, if you were to put together a consortium of community partners that were working to address childhood obesity in a rural community, yes, I mean, HRSA would be interested in that. So, I mean, there are specific grants that would be a priority area or something they would definitely be interested in.
Thank you very much.
The USDA also has, and we helped a hospital in Indiana to get this as a school-based initiative, which the name of which escapes me at the moment. But Carrie, what I can do is find the name of that specific opportunity and send it to you, and certainly you can share with the Kentucky Rural Hospital Association and the Virginia Hospital Association so that their members can take a look at it. But I know that this hospital in Indiana, obesity and some other childhood issues were primary targets of their application, and I think they just finished up their third year of funding through that particular opportunity. So there are opportunities out there, whether they say obesity or not. It is a huge concern, and so, you know, certainly I would consider applying for any of these that, you know, we mentioned today, as well as I'll get the info on the school-based initiative through USDA.
Thank you again.
Great. So let me ask if we have any additional questions from the audience at this point. And while we're seeing if any additional questions come in, let me let you all know that on the screen in front of you, you certainly have contact information for Gwen and for Louise, and we can circulate that afterward as well. And there's contact information for Carson and for myself as well, and we're happy to follow up with you. Both Gwen, Louise, and Carson and I would certainly be happy to schedule a half-hour telephone call with anyone in the meeting here who is interested in discussing any of these opportunities further. That's something that we're certainly happy to do, and provide any additional support to VRHA and KRHA as need be.
One topic I'd like to bring up real quickly, because there may be some people on the call who are in this space, but Carrie, all of the things that you have in particular been looking at in the post-acute space, in the relationship of post-acute providers in rural America who might partner with hospitals or form their own independent groups. Gwen, you talked a lot about community support, and we're seeing that post-acute providers can have a tremendous impact on reducing costs, particularly in lowering readmissions.
Yeah, that's right.
Exactly.
This is, go ahead, Gwen.
No, I was just going to say that I agree that at least in our conversations with clients as we do various applications for them, that it's inevitable now that we always see post-acute community partners involved in the conversation.
That's good. I think that's going to be an increasing trend.
Yes, definitely.
I think that's right. I think that's right. I was at the National ACO Summit last week, and they focused a panel on the frail and elderly populations, and there was a lot of talk among ACOs that were there that this is an area where they need to think very carefully about their partnerships, because post-acute plays such an enormous role in providing lower cost care in very quality settings. So that is definitely something that's getting more attention.
Great.
Well, I'm not seeing any additional questions come across the monitor right now, so I just want to thank once again all of our attendees for participating, and to thank Beth and Tina for sending this resource out to their members. And we look forward to continuing the conversation with you all. You have our email addresses here on the slide presentations, and we'll get the slides out to you. And in the event that you do want to follow up with a phone call with us, please just email one of us and let us know, and we'd be happy to do that. Terrific. Thank you, Gwen and Lee and Carson. And we'll talk to you all soon.
Thanks, Jerry.
Have a great afternoon, everyone. Bye-bye.
Good day.
Thank you.